We're good? All right. Welcome, everybody. Please enjoy your lunch. Continue to do that. That's very important. We wanted to make sure everybody had something to eat while they were here, and thank you for taking the time to come here live. I will say we also have a webinar version going on, so if we'd like to initially start with a roll call for anybody who's on the phone and on the webinar version. If you could just shout out your name, please. No? Nobody? Nobody yet? All right, just let us know. So we don't have anybody on the webinar version yet. So for those of you who don't know me, I'm Dr. Karen Williams. I'm one of the medical directors for the North Country Initiative. I guess I drew the short straw from the three of us, and I will be presenting our care management program today. Who else do I have with me here today? We have Joanna. Everybody knows Joanna, right? She's with us for a few more weeks till she has that baby. And Laura, who's helped me develop this talk today, and then Elliot's doing our IT for us. So welcome, everybody. Okay, so what are our goals today? One thing, we've been focusing on care management, CCM, TCM for years. Since I've been with NCI, it's been an integral part of what we've been doing. We've grown from just doing care management to, we started off by training our chronic care professionals, to trying to do some disease-focused care management, to really get care management a part of our culture within our region. We've done the transitional care management, which has been another big campaign, but there's a lot of questions that people still have. We have partners who are all in various stages of implementation of these processes, and so we really wanted to put together another care management program that we could really understand some more of the components, have questions answered for people, because once you get into it and you think, okay, you read about care management, it makes sense to you, but then all of a sudden you start doing it, and that's when you have the questions. So we want to answer some questions, we want to define some of the strategies, we want to share some success stories from some of our partners, some challenges from some of our partners, and really try to unify our region with regard to our care management strategy. Okay, so the first thing we're going to talk about is TCM, Transitional Care Management. Taking care of that patient when they get out of the hospital, all right? It's the beneficiary transition to the community following a discharge. That's a discharge from the hospital, discharge from skilled nursing. And that's basically the healthcare professional receiving that beneficiary post-discharge back into the community setting, right? We're saying, okay, we're tapping in now and we're gonna take care of this patient. They're not an inpatient anymore, we're gonna take responsibility. And the way this is kind of defined is either moderate complex or highly complex, depending on the medical decision making and also some of the timing. How many of you are actually actively participating in the TCM process right now? Okay, good. So I think most people are doing TCM, and as you probably have recognized, it can be a little bit of a challenge, but it can also be very, very rewarding. So what are the components of TCM? It's that interactive phone contact. It's a certain non-face-to-face services and then a face-to-face visit. That interactive phone contact has to take place within 2 business days of discharge, okay? 2 business days of discharge has to take place. You have to document at least 2 attempts to contact that patient. There's a lot of questions, and we're gonna get to these as we go through this presentation. There's a lot of questions regarding this phone call as far as, what if you don't have a discharge summary? What if you don't have, what if you can't reach the patient? We're going to address some of those challenges as we go on, but just understand it needs to be within 2 days. You need at least 2 documented attempts within those 2 days, okay, to try and get a hold of these patients. It needs to be a clinical staff member making this phone call, right? Your receptionist cannot be the one making this phone call. The whole point of this phone call is to get a hold of that patient as soon as they get back into the community and start identifying the care gaps, start identifying what's missing. Did they get their medications? Do they have rides to their specialty appointments? Do they have their specialty appointments? Did their hospital beds get delivered? Do they have a commode? Do they have a walker? Are they taking their blood thinners after their joint replacement surgery? It's to really identify those things that should not wait until 7 or 14 days when they come in to see the clinician, all right? If you don't get a hold of the patient, you just have to keep documenting, and you should continue to document your attempts to reach that patient even beyond 2 days. So two documented attempts within those first 2 days, but that doesn't mean you stop calling. You should still continue to document that you're trying to reach that patient. And then there are certain non-face-to-face services that need to be done before that TCM visit can be done, okay? And there's different people who make those non-face-to-face services, but that revolves around obtaining the records from the hospitalization, getting the consult notes, getting the op reports, getting the discharge summary, getting the H&P, following up on any labs that may have been pending at the time of discharge. The hospital records do have to be reviewed by the clinician. Okay, that has to be the MDDO NPPA that's looking at those, right? And you cannot have your care manager review all the hospital records and have that count. The clinician does need to review those records. And then the face-to-face visit takes place within 14 days, okay? So here's some more detailed components of what TCM is. You have your 99495. This is your moderate complexity TCM. It needs to be done within 14 days of discharge. One thing I want to point out to you guys is that phone call has to be within 2 business days, okay? These time frames are very much calendar days, and the clock starts ticking at discharge, and that's day 1, okay? So if they're discharged on a Friday, day 7 is going to be Thursday. Doesn't matter if it's a holiday, doesn't matter if it's a weekend. So that's a distinction that needs to be made when you're thinking about these time frames. It's not 7 business days. So, or 14 business days. So you communicate, you document your communication, you document your phone call. You need to have medical decision making of at least moderate complexity. The moderate and high complexity, people at where, well, what does that mean? That's all based on your E&M manual, your evaluation and management codes, and what falls into a moderate or high complex visit. That medical decision making is always the clinician's responsibility to make, okay? So a 99495 is within 14 days. A 99496 or complex TCM, this is within 7 calendar days. The face-to-face visit is within 7 calendar days. The criteria, exactly the same. You have to have the phone call. You have to review the documentation. One distinction here is that if you see a patient on day 6, but the patient is super straightforward, like not really sick, you can bill a 99495. But if you see a patient on day 8 and they're a train wreck, you cannot bill a 99496 because they're outside of that 7-day window. All right. If you try to, it will get bounced back because they're too late. So you can undercode, I guess, for lack of a better word, at that 6-day visit. You can do a moderate complexity as opposed to a high complexity. But if you fall outside of that 7-day window, you cannot do a high complexity. Okay, so that's a little overview on TCM. Now we're going to address some of our partner questions. When we went out to our partners, we gave the save the date, but we also asked for some feedback from you guys so that we could address some of the concerns that you have. So one question is, what are the distinct data requirements and who can perform what level of staff for billing for the various insurances? Okay. The rules are the same for every insurance. The phone call has to be clinical staff, and that we can't stress enough. We've initially had some partners try to have their scheduling person try to make that phone call, thinking, oh, we're just going to call them within 2 days to schedule their follow-up. That phone call has got to be clinical staff, okay? The non-face-to-face services, there's 2 pieces to the non-face-to-face services. The first piece is the reviewing of the hospital or skilled nursing facility documentation. Okay, usually it's hospital, so we'll just say hospital because it's easier. But the clinician has got to be the one to review that documentation, right? They don't have to be the one to track it down necessarily, but they have to be the one to review that documentation. So The staff, and it doesn't have to be clinical staff even, can work on pulling down those records, getting them routed to the clinician so that they can review them and have them available for them for their office visit at whatever within the 14 days. The clinical staff, but not the provider, the other clinical staff can do some of the other coordinating that needs to be made. If they need to coordinate with the cardiology office to make sure the patient has an appointment, or to clarify when the appointment is, or whether there needs to be a referral done, that can just be the clinical staff. But that's all considered the non-face-to-face piece of TCM, okay? And then obviously the face-to-face visit needs to be with the clinician. So document the phone call attempts, phone call needs to be clinical staff, MDDO must perform the blah, blah, blah. I just said all that. All right. How are other practices encouraging the patients to attend these appointments? Are people having challenges? Are any of the people here locally right now having challenges getting patients to come to these? Okay, so, all right.
My biggest problem is the staff is really good about getting them scheduled, but then the patient cancels or reschedules and they're out past their 7 or their 14 days.
Perfect. Okay. So I'm going to address this on kind of a couple different levels, but here we have kind of our written responses. Explain that it helps with their transition out of the hospital, right? Gives the practice the opportunity to make sure everything's all set. All the reasons we know that TCM is important, okay? Some patients still hesitate. It's especially helpful if these patients are already in care management and already know the care manager. That's one way where you can really kind of influence these patients to come in, is if the care manager has built a rapport with these patients. And even if the patient won't consent to care management, if they still continue to kind of hear from that care manager and they know your voice and they recognize you, then they may be more willing to respond to you. My big beef or thing here is educate every single staff member on the importance of this, right? So when they call to reschedule that appointment, whoever is on the phone, the receptionist or whoever happened to be sitting by the phone that minute, can say, this is a TCM appointment. This is really important that you keep this. We really don't want you to reschedule this because, you know, the doctor, the nurse, practitioner, the PA really wants to see you for this appointment. And I personally, in my practice, have found that to be extremely helpful. Now, I have a pretty little practice and I don't have a lot of people who work for me. So it's easy to kind of influence that, but it's a real culture shift. And it's something that I think if you do start to embrace, either as a care management or on some sort of a management level, where people start to realize that this is important for everyone to know. TCM isn't just important for the clinical staff to know. It's not just important for the care manager to know, but it's important that everyone understands why this visit is so crucial, okay? It's also important from a clinician standpoint. So in my practice, if a patient cancels an appointment, we usually get notified, and then we can always kind of push back and say, no, you gotta call them back, you gotta get them in here. It takes some work. It does take some work, but if you really stress to those people in your practice who answer the phone how important it is, because the timing is so crucial, how important it is, that I think you'll find a little bit more success getting some of those patients to come in. And, you know, a lot of times we just kind of phrase it as, look, it's really important to Dr. So-and-so that you come in for this visit. You know, they saw you were in the hospital. They want to make sure everything's okay. They really want to see you. That typically helps. Does anybody have any questions on that?
We try to call our patients the day before the appointment because they don't usually want to cancel right to your face, you know, and it reminds them that their appointment is there. And then
do you do that for everyone or just for your TCMs?
For our TCM.
Okay. That's a really good idea. And you know, there might be automated appointment verification things that go out, but if you do that personalized touch, you know, it can be very beneficial. Yeah.
I've been trying to, I work for the clinic, so my circumstances are a little different, but we try to schedule them all within 5 days because it gives us that opportunity, because often it'll be the third appointment before we actually see them. you know, it's raining today, people don't come, it's snowing, they don't come, because they walk.
Right, and that's an excellent strategy as well. In my practice, my directive is everybody is scheduled within 7 days, and then I'll make a decision whether it's moderate or high complexity. But I don't want to lose out on the opportunity to bill a high complexity visit if it truly is a high complexity visit. I'd rather just bill a moderate complexity at day 6 than to lose out on a high complexity. But it also does give you that little bit of a buffer for trying to get them back in. You'd also be surprised that some of these patients who you think are going to be super routine, by the time they get into you, they're actually not, and they do turn around and end up being high complexity. So, okay. Just a little kind of, I don't even know if you can see that all the way down here. For, especially for those of us who are in private practice, and I think anybody cares about generating revenue, because without revenue, we don't sustain our existences. Lots and lots of insurance companies pay for TCM. So your TCM program should be fairly robust, because there's only a couple of insurance carriers that don't pay for it. And it does pay well. It pays well for a reason. It's a lot of hard work, but we also have a ton of evidence and data that shows that it keeps patients out of the hospital, it saves costs, and we might as well get paid for the work we're doing. So get a process down where we can do it and bill it. But a lot of insurances pay for it. Okay. Can TCM be performed without receiving the discharge information within the 2-day window? Excellent question. Nobody has a discharge summary within 2 days, right? I mean, very rarely do you have a discharge summary within 2 days. They're getting better, but it's not perfect. So absolutely, TCM, there's nothing in the TCM rules that say that discharge summary has to be available for you to make a phone call. What are some of the strategies you can do to perform that phone call? I'll share some of my ideas, but some of you guys making these calls can share your ideas as well. One thing is that we do is we use the CCD if we have it. Oftentimes we're getting the CCDs way before we get the discharge summaries. They're a little cumbersome to work through, but you can at least get a med list on what the hospital thinks they're being discharged on. Okay, so you can work on that med reconciliation. The med reconciliation is not required that it is done in that 2-day phone call. That just has to be done by the time at or before the face-to-face visit. So the last opportunity you have to do your med reconciliation is at that visit, but ideally it's done before. So you can use the CCD. Sometimes we don't have a CCD. So my care manager will call the patients up and say, pull that folder you got from the hospital and get that piece of paper out that the nurse wrote on. Read me what it says, and they'll go through it that way. So you have to be a little creative sometimes. Sometimes we do it just based on maybe the H&P and one consult note, and then we continue to work to get the rest of the documentation. So yes, you can do it without a discharge summary. Is it easy? No. But you can do it. Does anybody have any other strategies that they're using when they don't have the information available?
If they've had like orthopedic surgery, sometimes we do see them. You can check an eye stop. You can find out what narcotics they've been given and how many, and also sure scripts. If they've signed an agreement, then you could go in and check the pharmacy before you call them and see what they filled. That's helpful.
That's an excellent idea. Good point.
Yeah.
Sure scripts, and if they don't have sure scripts, you can always just pick up the phone and call the pharmacist.
And then I just go off their chronic care conditions. If they're diabetic, you say, well, what was your finger stick today? Because that's going to affect their condition, no matter what they were in the hospital for, infection or whatever.
Yeah, their sugars are going to be high.
Certain little things like that.
Yeah. So yes, you know, if you had a discharge summary, would it be nice and clean and easy? It sure would be, but I'm pretty sure chronic care managers in a former life were all private investigators, because they found a way to get this information somehow, okay? Somehow they're getting this information. So those are some of our TCM questions. So what are some of our strategies for success that we have? One is making sure you have a good process for who's receiving discharge alerts. How are they communicating the alerts to the staff? How is discharge information gathered? Have a process for that. You know, don't just kind of willy-nilly sit around waiting for discharge notifications to come to you, but have a good process. Have a well-defined workflow. Use all your resources. Don't put all your eggs in one basket of discharge notifications. Use the HIE. Use, you got an H&P, you know that somebody's admitted, track their admission. Use the CCDs, patient's discharge paperwork, kind of use all that information. How do you frame it to patients? Well, basically what people are saying is, tell them why it's important. We don't want you to end up back in the hospital. We want to make sure you don't end up back in the hospital. We want to make sure that we know everything that's going on with you so that we can take the best care of you possible. And we can't do that unless we see you. How do you conduct the interactions? Well, try to make the most of it. I like to think of TCM as a launching pad to CCM. Patients who have been in the hospital, especially our elderly patients, oftentimes probably should be in CCM. Why'd they end up in the hospital in the first place? Unless it was just that hip surgery or, that elective procedure. But, they ended up in the hospital for COPD exacerbation or something else. Do they have two chronic conditions? Should they be kind of morphed into the CCM process? TCM visits, if you ask any of your providers how they feel about TCM, my guess would be they would say they absolutely love it, right? Gone are the days of me having a 10-day hospital discharge, knowing that patient was going to be there for an hour and 50 minutes of it was going to be people running around trying to find information on why this person was in the hospital. By the time that patient is in, I don't even have to do anything, to be honest, right? I go in, sit down, chit chat with them, ask them how they're doing. My care manager's done everything else, make sure they have everything they need and all their visits are all nice and tidy, and then they're on their way. It's great. It's great. It's great for patients. And I can't tell you how often, and you guys are care managers, you've probably heard this, how many patients have thanked you for checking up on them when they got discharged from the hospital, right? Wow, you knew I was in the hospital? Yeah, we track everybody. We know you're in the hospital and we want to make sure that you're getting the best care possible when you get back in the community, so we want to see you. And we're going to make sure we have an appointment available for you. So patients really like that, okay? It's super important, if you're going to put all this work into it, it's super important that at the very, very back end of it, that those visits are being billed correctly, okay? We don't want to put all this work into doing a TCM visit and then bill a 99213 or a 99214. So we have to make sure that everybody is educated, and this is where it comes back to making sure that the entire staff is educated on what we're trying to do, because the billing staff matters too. The person answering the phone matters, and the billing staff matters, because if the clinician puts in a 99214 because they're, were busy or fuzzy-headed or whatever, they just couldn't remember that it was a 99496, then the billing staff could pick up on that and go back to them and say, hey, this is a TCM, let's make sure we get paid for it, okay? Okay, that is my last TCM slide. So before I switch gears to CCM, do we have anybody on that would have any questions? Because I forgot to tell people online that they're, okay, because nobody was there. Okay. Are there people online? Okay. If there is anybody that is on the phone and you have a question, please use your chat feature to type in a question. There's a slight delay, and we will get to your questions when we come back around. So don't think we're ignoring you, but use the chat feature, please. Okay. Yes.
We had that blizzard and we closed for a day and a half.
Mm-hmm.
And that's normally would be a business day. What happens there? Are they considered non-business days? Because I had several TCMs due to call them.
Well, if you ask me or if you ask CMS, you might get a different answer. However,
the people paying me, what are they considered?
If I were paying you, I would say that we would call that a non-business day. And if they denied the claim, we would send an appeal stating that there was a blizzard, the office closed, it usually was a business day, but the office had to close for weather, just like it closes for a holiday, like Christmas is a non-business day if it's on a Wednesday. So I would call that a non-business day. because it was on the news, you know, Watertown Internist is closed. It's not like you just didn't come in because it was snowing, right? It was closed. So I don't know what CMS would end up saying about it, but I would try and bill it and then, you know, beg forgiveness if they deny it and say it wasn't within 2 business days. But, you know, still call them Monday when you get back after the blizzard, right?
Right.
But I'm not CMS, I'm not making that rule, so I can't say for sure if they would pay it, but I don't think it would hurt to try. The worst thing they're gonna do is deny the claim and you send it back as a 99214.
Okay.
Somebody else had a question, yeah?
Will we be provided with the PowerPoint?
With the PowerPoint? I think so. Are we sharing
We
it?
can
Okay.
do that.
Okay.
It's easier
Yes.
than right now.
Yes.
Right.
Yeah.
Yes.
Thank you.
You made a comment earlier about, following up with the patient with their anticoagulants after their knee replacement.
Mhm.
Okay. I was under the impression that you could do a TCM for a planned surgical procedure.
So, okay, that's an excellent question and I would love to clarify that.
Okay.
You absolutely, positively, 100,000% can do a TCM for any hospitalization or observation status. You can, okay? And many of those you should be, all right? What we have done, because a lot of our 66-year-olds on Medicare with no chronic medical problems who still run marathons, who just go in for a routine knee replacement, they don't need a TCM, okay? They might, you know, if they're 80 and they go in for a knee replacement and they have CHF and diabetes and other things. However, because all of our partners are at different stages in their development of their TCM process, we have a goal for our TCM patients, and we want to make sure we're really, really focusing on the sickest patients who truly need it, okay? So we've said, we're not gonna penalize you if you don't do TCM on straight up orthopedic joint replacements that were planned, because we wanna make sure we're really focusing on our sick patients.
We
Okay.
TCM everybody.
So then you get bonus points, right? And I think most of us too, like we track all of our admissions, and some of them by the end of the admission, it may be very clear that that patient just does not need to come in, and we might not bring them in and do it. But you know, a lot of our joint replacements do need TCM, so it's not that you can't. You every admission, what practice do you work for?
River.
Okay, so every admission should be tracked, and if you TCM them and you do the TCM visit and you can get the patient in, you absolutely should get paid for that service, and it's not that you can't do it. Other questions? Yes.
Do you know which of the payers are not paying for it?
I
know it's kind of off the top of your head question, but.
gotta take a stab out there. I'm pretty sure that TRICARE does not pay for it, but I'm guessing here. Okay, so don't hold me to this. I'm pretty sure TRICARE does not pay for it, but I think Martin's Point does. Mike, do you know, or okay. There's another one that doesn't pay for it, and I wanna say POMCO, but it's not POMCO anymore. UMR. Yeah, so, I bet it might not be them, there might be one other.
Well, here.
All of the Advantage plans pay for it.
Right.
All of the Advantage plans pay for it, and the biggie, the Blues, pay for it. So, I mean, the worst case that you get is if you have a patient and you TCM them and they have one of those insurance that doesn't pay, then they bounce it back, they deny the claim. This is again why it's important for your entire organization to be on board. So when that claim comes back and then they realize that, okay, this insurance doesn't pay, then, all right, you rebill it as a 99214 and you move on. Takes a little longer to get your money. The next time around, you just make sure that you kind of have that flag in your head that you don't bill the TCM on that particular plan. Other questions on TCM before we move on?
We had one come in from online.
Okay.
Who are considered clinical staff RN, LPN?
Okay, that's an excellent question, and I think we might get to that a little bit later on, but I'd be happy to kind of put it to bed now. The question is, who are considered clinical staff? When you go through the CMS documents, and I've been through a lot of them multiple times, clinical staff are considered the people who would not normally be able to bill a service. So your clinical staff are social workers, LPNs, RNs, typically kind of viewed loosely as those licensed staff who cannot bill for their services, right? Nurses don't bill for their services. Some social workers do, we're gonna assume it's a social worker that wouldn't bill for their services, okay? So the gray area comes in with what do we do with our medical assistants? Okay, New York State doesn't recognize medical assistants as licensed professionals. So it's kind of a loose interpretation, and what people have interpreted the medical assistants to be is if their primary role is clinical, and what they do is back office, clinical, rooming patients, dealing with patients, then you could consider them part of your clinical staff, if their primary role is clinical. There's no written documentation that supports that, but that's the interpretation that's kind of out there on CMS. So your licensed staff, easy. Your medical assistants are difficult, but they basically have to have a role or a job description that is primarily clinical. That's an important distinction because when you look at some of the medical assistant training that's out there and the medical assistant certificates that come from other states, we have a big military population, people coming in from other states who are certified medical assistants. A lot of those are administrative, right? So a lot of medical assistants are administrative. They would not be considered clinical staff, but medical assistants whose primary role is clinical could be considered clinical staff. Okay? Any other questions before I move on? Now we're going to talk about CCM. CCM's a little less cut and dry than TCM. TCM, we know, saves us money. We know generates us money. It's kind of, you know, neatly packaged and easy to do. CCM's a little bit of a bigger bear. So CCM qualifies for patients with 2 or more chronic conditions that are expected to last at least 12 months and show a high risk to put them for acute exacerbation, ER visits, or hospitalizations. CCM is your typical non-face-to-face visit with a focus on continuous relationships with a designated member of the care team for patient support, chronic disease management, preventive care, comprehensive care planning, right? It's your continuity with these sicker patients who are likely to wind up in the emergency room or in the hospital. It does require patient consent, and this is super important. You cannot bill Medicare for CCM without patient consent. Consent can be verbal or written, but you have to have consent. And only one practitioner can be paid for CCM services during a calendar month. Typically, it's the PCP, and that's what we have in here is our primary care providers. But we've had a couple of issues with some specialists who started to dabble in some CCM, and we think that's ending, but we're not entirely sure. So anyway, only one practitioner can bill CCM a month, okay? So that's important. So what are our CCM codes? We have our typical straight up CCM. This is your 99490, right? 20 minutes of clinical staff time directed by a physician or qualified healthcare professional, NPPA, MDDO, right? They have to have 2 or more chronic conditions. They have to last 12 months. They have to, or to the death of the patient, they have to be at risk for exacerbation. You know, so your Medicare patients with hypertension and hyperlipidemia, probably not your best CCM candidate, right? Are they likely to end up with an acute exacerbation in the next, you know, couple months? Probably not, if they're well controlled. But so there is that piece in there that they have to be at risk. They have to have 2 or more chronic conditions and be at risk. And you have to establish a comprehensive care plan. It's important to also remember that this code, 99490, assumes that 15 minutes of the time spent in the month is kind of directed by the physician. So the physician is, you know, participating in the care plan, answering questions, responding to questions from the care manager. Then you have, this is a new code, this one, the G, I don't know why we had to switch from 99s to Gs and just because it's CMS and we have to be complicated. But our G code here, G2058, this is new and this is for each additional 20 minutes. So before we would build CCM and you could bill for 20 minutes or 60 minutes. How many of you got caught in the middle at 35 or 40 minutes? And you just spent, you know, you could have done CCM on a whole nother patient that month, right? Jen's shaking her head over here, right? So now we can bill in 20-minute increments, which is super exciting, okay? You never bill this G code without first billing your 99490, and it's an additional 20 minutes. So you have to document. Shouldn't use slang. You have to document, and you need to reach 40 minutes in order to be able to bill that G code. Okay.
I have a quick question.
Yes, Jen.
So typically, a lot of the people that I talk to, there's some that are very simple, very easy. They're the 20-minuters. They're fine. But a lot of the patients, they're 40s. They're 40s and 45s.
Mm-hmm.
So for billing, they would do the first 20 minutes under the 99490,
Mm-hmm.
and then the other part of that would go under the G2058.
Correct.
Okay, I just wanted to make sure.
And I believe you have to send them all together.
That's what I'm
So
wondering.
I can't speak to that 100% because again, this code just came out in January. So I can't speak to that 100%, but I believe you cannot at 20 minutes bill your 99490 and then later in the month send out a G2058.
Right, it has to be that one.
You have to send them together.
Okay.
Okay?
Yeah.
So now there's also this exciting new little code, which is your 99491. This one actually came out in 2019 and it kind of slid under the radar for all of us. This is a code for 30 minutes. It's not 20 because we gotta keep things not simple because we're CMS, okay? So it's a 30-minute code, but it's 30 minutes of physician or qualified healthcare professional time. But if one of your clinicians has a super complicated patient who they spend 30 minutes in a month coordinating care for that patient, they're on the phone with specialists, on the phone trying to do a peer-to-peer for a prior authorization. If it is time specifically spent by the clinician and they have to spend 30 minutes, so they're not directing anybody else's care, they're personally providing the service, it is a code that you can bill for 30 minutes of time for the healthcare professional. Now you wouldn't do it every month, but there might be 1 month where you have a CCM patient who's super complicated, and instead of billing your 99490, you bill that 99491 because the clinician themselves had to do the lion's share of the work. So it actually pays quite well too. It pays about the same as complex CCM or the 60-minute CCM. So just as you care managers are keeping in the back of your mind, your patients that you're care managing, if there's a month where one of your clinicians is really spending a lot of time on the phone, be thinking about this code.
How do you document that? Do they ask for that?
They can ask for documentation, so you ought to document it. Now, we all document our time. Documenting time is difficult. Do you guys use the CCM flow sheet? You guys have you're a med-ed practice. Do you use the CCM flow sheet?
Yeah.
So your clinician would just have to go into the flow sheet, say, I spent, you know, and say, on the phone with Dr. Willis discussing care management or, you know, case or whatever, and then just click the little button and say, and that's their time.
That's your
Yeah.
documentation.
Do your clinicians document their time at all?
No, not for that stuff.
So I document all my time for my care management patients. It doesn't have to be just the care manager providing the service, right? So when I get labs back from a patient and I end up reading a discharge summary or a consult note and I'm, you know, looking at it, filing it off in the chart, I go right into that flow sheet. I say reviewed consult from Dr. Willis, 3 minutes, move on. Do they want to get paid?
It's more clicking.
It is more clicking, but I tell you, you know how easy it is to get to 20 minutes when everybody that's clinical is documenting their time. My nurse is not my care manager, but if she takes a call from one of my patients, she's documenting her time. My care manager documents her time.
Okay.
All of my clinicians document their time. Med refills come in, I have to go through them, I have to look at them all, 2, 3, 4 minute increments closer to that next 20 minutes.
Okay.
Yeah, that would add up to the money on certain ones, and then when there's problems, the doctor will address it.
Okay, some more guidelines for chronic care management. Okay. You have your complex CCM, I just referenced this a minute ago. This is 60 minutes of time. It does say here that there has to be establishment or substantial revision of a comprehensive care plan. Great news 2020, that's changed. We're going to talk about some of the 2020 highlights here towards the end. It does need to be moderate or high complexity, but you all have that handful of patients who you are just on the phone with all the time. Once a week, you're on the phone with them for 10, 15 minutes or whatever. When you get to that 60 minutes, you can build that complex CCM. Anybody who outsources their care management, complex CCM cannot be outsourced. So a third party cannot do complex CCM. So if you're using, some people use Signal Lamp, some people use something else. I don't remember what it's called.
I know which one you mean.
But if you're using a third party to do your CCM, they cannot build complex CCM. That has to be done in-house, okay? And then you have your 30-minute add-on code for your 99487. And then this is another code that's very important to remember, and that's your GO506. This is a clinician code. This is a code that is billed by your provider at a face-to-face visit. So if you have a patient entering care management and that provider is like, you need to be in care management, this is what we're going to focus on with your care plan. It's your initiating CCM code, right? You can build this with an annual wellness visit. You can build this with any E&M code. You cannot build this with TCM. That's one thing you cannot do. You cannot bill anything else with TCM, so you can't bill a 99213 or 4 or a GO506. But if your clinician builds a GO506 with a 99213, 99214, they can do that. Are you telling me I have to hurry up?
Yeah.
Laura's telling me I have to hurry up. She's the one who made the slides.
You were halfway through. I'm like, oh.
All right. So this is just another quick personal billing, blah, blah, blah. We'll give these slides to you. This is that you licensed people are doing work on behalf of the clinicians, and we're not billing under the nurse, you're billing under the provider who's supervising. This is what, this is a slide that we compiled, and basically it takes the CMS recommendations for a care plan, and it takes the PCMH requirements for a care plan, and it puts them all into one list on the type of information that should be, if you do all of this, it meets criteria for both, okay? All right, so let's get to some questions, the important stuff. Partner CCM questions. What are the distinct data requirements and who can perform what level of staff for billing for the various insurances? Well, Medicare is the only insurance that covers CCM, but all of the Advantage plans do cover it, okay? Nobody else has really caught up yet on CCM. What are the distinct data requirements? You need to document your time. So if you're billing a 20 minutes, you need to have somewhere a flow sheet, a spreadsheet, a scratch pad, whatever you're using to document time, you need to document your time, okay? Other than that, you need to have your care plan and you have to have documentation of patients, either verbal or written consent, okay? How are care plans done and how often are they updated? Well, I kind of showed you what could be done in a care plan, but how are they done? LPNs cannot write care plans, RNs can write care plans under the supervision of the clinician, MDDO and BPA. So everybody kind of does it a little bit differently, but most offices have the clinician kind of say, this is what we should focus on. The RN writes the care plan, the clinician signs off on it, and then that becomes the care plan. They're updated as often as they need to be. CMS doesn't give distinct recommendations on how often they're updated, but they do say kind of as needed. The general rule and the way that the rule is interpreted is they should be at least looked at to be revised every 6 months. More if there's any major change in their health, okay? how to get CCM patients identified and signed up, and how have others done with this? Well, identifying, great news, is a little bit easier. We do supply a list of high-risk patients to all of our partners, and if you're just getting started in CCM, that list is a great place to start. 2 or more chronic conditions likely to have an exacerbation. How do you get them signed up? And that's just getting patient buy-in. And that's where it's really important, once again, for your entire staff to be on board with this, right? So you can't just have one person want to try and sell CCM to everybody, but you know, you got to get your clinicians on board saying, hey, I really think you'd be good for this program. Let's get you into it. Our care manager is going to make you a VIP, and we are going to make sure you have someone to talk to every time you call. We're going to make sure you have an appointment whenever you need it, and we're going to take really good care of you. Okay. Did I miss anything on that one?
I'm just lost.
We're still on question 3.
Oh.
All right, can you bill more than one CCM service within a 30-day period? You could bill like that 99490 code with the appropriate add-on code, but you can't bill CCM and complex CCM. So it's kind of like you go one row or the other, okay? You can bill CCM whenever you meet the timestamp, but once you bill it, then you're done for that month, okay? So you can wait till the end of the month and bill them all, or you can bill them once you meet it. Can you bill CCM and TCM within the same 30-day period? Who wants to answer the question? Anybody?
Yeah, you can now.
You can now. That's super exciting. You could not before, which was real bummer, especially if one of your CCM patients was in the hospital. You're still taking care of them the whole time. You want to be able to bill their CCM. All right. What is required to bill CCM? I will not go through all of this in detail because you're going to get the slides, but it is important to note that if you have a new patient or a patient who you have not seen in your practice within the last year, you must see them and have a face-to-face visit before you can initiate CCM. If you are going to outsource your CCM with that same patient, new or someone you haven't seen within the last year, your documentation must state that you, as the clinician, talked to them about CCM. If you're gonna outsource it, okay? So you can't start CCM on patients you've never seen before, basically. You need to have a structured EHR. Great news, we're all part of this wonderful organization, and we all have certified EHRs, so we don't have to worry about that. 24/7 access, continuity of care, written or verbal consent, and the rest of it is just what you're doing with care management. You know, you're focusing not just on their chronic diseases, but their preventive care, your med reconciliation, you're keeping that up to date, oversight of self-management. They have a care plan. The patient needs to get a copy of the care plan, so you should be documenting that the patient has a copy of the care plan, and you have to document your time. I went through that one really fast. Am I catching up now? Okay. All right. Here on CCM, what's new in 2020? That G0258 for your 20-minute increments. That's going to be great. Complex CCM no longer requires significant care plan change. So if you're putting in the time, you can bill it. TCM reimbursement went up this year. Yay, that's super exciting. And they also added 14 concurrent billing codes with TCM, including CCM. So that was super exciting too. So you can bill TCM now when they have CCM. And then this new program that's out, PCM, we haven't focused on it too much, but it's very much like CCM, except that it's one chronic condition that's exceptionally complicated. It's in lieu of CCM, you cannot bill them together. Initially, when this code came out, we were kind of excited. We thought this might be the code that the specialists could use to manage heart failure or to manage coronary artery disease while we manage the whole patient. That is not true. You can't bill them together. But if you have someone with one super complicated condition, chances are they have another. But if you have one with one, you can look into this PCM program, which is new in 2020. Now we're going to take a tiny little break and we're going to show a video that kind of pulls some of this talking to patients about self-care and taking care of themselves a little bit. So I can stop talking for a minute. And I am not in charge of the technology. So.
Is there volume in that?
Hi, I'm Dr. Tom Bodenheimer. I'm a physician at San Francisco General Hospital. In this video, we will review two important topics involving interactions between healthcare teams and patients. The first topic is healthy behavior change. The second is about patients taking their medications. In both cases, the goal is to encourage patients to become informed and activated to self-manage their chronic illness. Let's start with behavior change. For years, health professionals have demanded that patients eat better and exercise by scaring patients or begging patients to make those changes. That rarely works. Healthy behavior change requires making an agreement between caregiver and patient, and we call that agreement an action plan. Let's look at the first interaction between Victoria, the community health worker, and Senora Romero, who is a patient with diabetes.
Senora Romero, I'd like to show you this chart of your hemoglobin A1C.
Okay.
It looks like your hemoglobin A1C is about a 10. You should be about a 7. So you have to bring it down from 10 to a 7.
Okay.
So this means you're going to have to increase your exercise, eat a little bit healthier, and you probably have to take an extra pill prescribed by your doctor.
Okay.
So put this graph on your refrigerator, and that should keep you motivated.
Sure.
What just happened? Victoria has no idea if Senora Romero understands or agrees with what has been said. It is doubtful that Senora Romero will do any of the things that Victoria recommended. In this dialogue, Victoria tells Senora Romero what to do and never asks what she thinks. Let's try it again.
I would like to show you a graph of your hemoglobin A1C. Is that okay?
Okay.
Has anybody ever explained to you what this graph is about?
I've never seen it before.
Okay, do you know what a hemoglobin A1C is?
No.
Okay, so a hemoglobin A1C is a blood test, which gives us another way to measure how well your sugar is doing. This is a graph that measures your sugar over time. This red line right here is your hemoglobin A1C. This is where you should be. You want your sugars to be 7 or below. So 3 months ago, you were at goal at 7, but now you're at a 10, which is pretty high. Does that make sense?
Yeah, so you're saying that I need to be at a 7 where I used to be, but now I'm almost at a 10?
That's right. What do you think about that?
Well, I don't like it. I want my number to be back to a 7.
Okay. Is there anything that you feel that you can do to bring your hemoglobin A1C down to a 7?
I don't know.
It's okay. You have different options. Here's an action plan that we use for our patients here at this clinic. You can improve your food choices by eating healthier. You can increase your physical activity. You can take your medications regularly. Is there something that you are willing to work on?
I'd like to work on improving my food choices.
Okay, maybe we can do an action plan around improving your food choices. Do you think there's something that you eat that causes your sugar to go up?
Well, I do eat 5 tortillas with every meal. Do you think that brings my blood sugar up?
Yes, it does. Do you think you can work on cutting down the amount of tortillas you eat?
Yeah, I'll cut them out totally.
Okay, that's good. But let's do a reality check. I just want to see how sure are you that you can stop eating your tortillas altogether. This is the scale we use to measure how sure you are. 1 means you're not so sure. 10 means you're very sure. Where do you think you lie in the scale?
I'm about a 2. I don't think I could give up my tortillas.
It's okay. We'll take it step by step. Is there anything you can do about your tortillas that you feel that you can succeed at?
I could eat 3 tortillas instead of 5. I'm 100% sure I could do that.
So that can be your action plan. When do you want to start?
Tomorrow. I need to get my A1C thingy down to 7 again.
Do you think there's a place in your house that you can put this graph to motivate you, to inspire you to bring your hemoglobin A1C down?
I'll put it in my kitchen.
Okay, great. Is it okay if I call you in a couple of days to see how you're doing with your action plan?
Yes, please.
Okay.
Thank you.
Okay, so what do you guys think of that video? It's pretty realistic, right? I mean, maybe not tortillas, maybe not all of our patients are having 5 tortillas with a meal, but we could talk to them about whatever they are having with their meal. It's just a different way of approaching your motivational interviewing, sorry, to really get patients to start to engage into their own care. So what is the value of CCM? And that's what we want patients to see. We want them to see the value. It's not just us keeping them out of the hospital. I mean, maybe they don't care about being in the hospital, right? What's the value to the patient? So, you know, we want to really promote independence with self-care. We want to try and improve the patient's overall care and well-being, improve self-management, person-centered care. I can't stress this enough. I know that whole person-centered care video that I had to make last year was really corny, but it's really important. We want to engage our patients. We need to meet them on their level, okay? It's super important to do CCM for these complex patients who are all over the North Country, and we can coordinate their care and we can make sure everything is in one place. It's one of the things you can sell to patients is, look, we want to make sure all of your information is in one place so that we know everything that's going on with you, and CCM allows us to do that. Also, the single point of contact, right? That fast track. You have a fast track to me. You are a VIP, very important patient. You get to call, you get to speak to me. You don't have to, you know, go through everybody else and yada yada. So, okay. So we want to identify patients who would qualify. We've talked about some strategies to do that. We want to explain what it means to the patient. Sometimes I have patients, I don't want to talk on the phone. I don't want to talk on the phone. So I'll have patients say, look, you just consent and we'll only call you if we need you. But chances are there are patients out there who you could not talk to at all and still do 20 minutes worth of work to coordinate their care because you're talking to other offices, you're gathering information, you're reviewing documentation. So, or I'll say, all right, you don't want to talk to us? Here's our patient portal. We'll just email you and you get back to us when you're ready. And then we check in that way. At any minute, you don't have to be on the phone with that patient. If you're just digging through paperwork trying to figure out what's going on with that patient, those minutes count, right? Count every minute that you're really focused on care for that patient, okay? It's important to be able to have a process in place where you can indicate in the patient's chart that they are a care management, a CCM patient, so that everybody is on the same piece of music with that and everybody is documenting their minutes and their contribution to that patient's CCM care. Annual wellness visit is another good time to identify patients for CCM and really kind of get them engaged because we do a lot of preventive focus at our annual wellness visits. And so if we're focusing on prevention and we're already talking to them about their colonoscopy and their immunizations and their AAA screening and their low-dose CT, and you know what? You really are complicated. So maybe you would be a good person for CCM. Oh, did I not go forward? Okay. Some of our communication strategies. Am I done? Like almost done? Okay. I'm gonna go really fast now. Basically, the take home here is just change how you talk to people, right? Instead of you need to do, you need to do, you need to do, how can we meet in the middle? And then this is another technique that really helps you engage your patients. When you want to try and get them to meet you in the middle, ask them these kind of questions, this bathe technique. What's going on? How does it affect you? What troubles you? How have you been handling it so far? How are you doing, right? And then empathize with the patient and try and get them to meet you. Okay, some of our partner challenges. Oh, a lot of them. A lot of them. All right, I got 4 slides to go. Are we like on a hard stop at 2?
If people need to leave, by all means, we're not capturing you here. But if you'd like to kind
But if we're not on a hard stop, I'll go through these.
you can take another 5
like-
or 10 minutes.
Yeah, it's at 5.
5
We can do
minutes.
5.
So again, feel free
we
to
okay
get
with
up
that?
and leave if you gotta go, that's fine.
Do y'all want to go back to your offices and start calling patients or just hang out here for a few more minutes, right? Okay. So partner challenges, some of our partner challenges, TCM, it's not getting those discharge notices and all that. We know that it's an imperfect system with the HIE, our discharge alerts. Again, use all of those different modalities and put them together. And I can't stress enough, track your admissions. Don't wait to track discharges, track your admissions. Get your admission notifications, figure out who's in the hospital, get them on your radar, and start planning for their discharge. We want discharge planners to do that in the hospital, we do that, okay? Assigning tasks and adjusting workflow, oh God, this is really tough because everybody is like, everybody's doing 2 jobs or 3 jobs or 12 jobs or 94 jobs. We got that, it's just really trying to drill down the workflow and educating everybody as to what's going on, okay? The unavoidable admissions in 30 days, they're still gonna happen. Great news, we've decreased them. We've decreased them by 5%, I think.
Yes.
5%. So, I mean, we have fewer unavoidable discharges than we did just by doing TCM, but we're still gonna have some, and that's still gonna kind of affect our TCM billing. But if we keep doing TCM, those unavoidable discharges are gonna keep going down. And the better we get at it, the more we can keep our patients out of the hospital. This is a biggie, family assisting. It would be super duper helpful if anybody does deal with any of the discharge planners in the hospital, if they could include where the patient's going when they get discharged, if they're going to stay with Aunt Sally, or, you know, they're going home, would be super helpful, but that's not always readily clear. So that is a challenge. Again, you guys are private investigators, so just keep using your private investigation skills to find these patients when they get discharged. And then we've kind of addressed the 14-day window. CCM, provider buy-in. I know every office has different feelings with their providers on how helpful they think this is. I think the more robust our programs get and the more developed they get, the more the providers will buy into it. But, you know, there's a huge difference between a practice where the care manager is the driving force in care management and a practice where the clinician is the driving force in care management. And obviously that latter is way more a path of least resistance than if the care manager is trying to drag these patients out from the clinicians. But just keep selling it. Keep selling yourself and your skills and what you're doing and how you're keeping these patients out of the hospital. And I'll tell you what, your clinicians get a couple of patients who have had great care management and they come in for that 6-month follow-up and they're not a train wreck and their med list is up to date and all the consult notes are in the chart and that clinician knows exactly what's going on with the patient, they're gonna start buying it. So just keep plugging away at it. Lacking care managers, again, we're all wearing multiple hats and that is a huge challenge. Low reimbursement for intensive services. I think we've made a step in the right direction this year in 2020 with that additional 20-minute code. So we're not limited to just 20 minutes or 60 minutes. So obviously CMS is seeing this as a kind of nudge. So they threw us a bone this year and I think we just have to keep working at it. Just get really efficient. And the most efficient you can be is to have every clinical staff log their time. That's going to be a culture shift for some of these practices, but if your clinicians are logging the time they're spending doing refills and reading consult notes and providing you direction, that's easily 5, 7, 10 minutes a month, depending on the patient. You know, you're halfway there, or you're halfway to that next 20-minute level. So if the clinicians are giving pushback on the reimbursement, then I would push back on, well, you know, if you log your time, we have twice as many. So that I think is one way to address that. No clear direction on how to properly code and bill services. Hopefully we cleared a little bit of that up today. We are not billing and coding experts by any means, but please reference these CMS handouts. You know, they have CMS has a FAQ on CCM billing that I don't know if we included that one, but it's a frequently asked questions. It's right online, cms.gov. FAQ on CCM, it's old. So one of their answers is wrong because it says you can't bill CCM and TCM because it's from 2019. But it does really clarify a lot of these, well, who can do this and who can do that questions. So, you know, reference that material. They have a lot of good handouts and shiny, glossy things that explain their program pretty well. And patients who are unwilling to accept services, hopefully you've learned something today about how to motivate those patients to accept services, right? Sometimes I say, you know, you don't want to pay the $8 copay. $8 copay is difficult for some patients. Difficult, or they just don't want to, if they don't have secondary insurance. If they have secondary insurance, usually they have no copay. But if they don't have secondary insurance, I say, you don't want to pay an $8 copay, but it costs a lot more to go to the emergency room. Your 20% coinsurance at the emergency room is a lot more than $8. You could do 6 months of CCM and still not pay your copay. So I sell it that way sometimes too. So some of the current strategies for CES, we have partners who are outsourcing their CCM, right? We don't have enough care managers, we don't have enough staff, we don't have enough room, we don't have a place to put more care managers. If we wanted to, we're gonna outsource all of our basic CCM and we're gonna just focus on this disease process or just the complex ones. And they generate a lot of revenue. Good news, our data shows that those patients who are outsourced their CCM versus the patients who have in-house CCM, they save the same amount of money. So it's just as good. It's what fits for your practice. Using your risk stratification tool in your EHR, if you put that into practice and you can really use that, it can help you identify and sift through some of those patients that are higher risk, right? It can be a little overwhelming to get a list of 40 patients coming in this week who have 2 chronic conditions who might be at risk for going to the ER. It could be a little overwhelming. But if you had a risk stratification tool and you could say, we're only going to focus on the 6s, or we're only going to focus on the 5s, or whatever, it might help you, okay? And then TCM, whiteboard manual tracking, we have some practices who do that on a whiteboard, right? These patients are in the hospital right now, and we're going to wait for them to come out. There's different ways of tracking it, and if you can do that, then you can anticipate those discharges. Interestingly, none of our partners said that finding appointment availability for TCM appointments was difficult. So that's great news. We're getting our patients in for our TCM visits. It's just, we're getting them scheduled. Getting them in is sometimes more of a challenge, right? Okay. We've already kind of done this, right? The care plan's fluid, updated, changed as needed, why it works. We're building relationships with our patients. We're keeping them coming back. And I think I have one final closing. All right. These are just some closing remarks. I think I've stressed most of these, but again, everybody has to have multiple roles. Even if we're a big practice with multi-sites like Samaritan, or we're a tiny little office, everybody in that practice has to have multiple roles, and we can't leave CCM just to the care managers. It's got to involve it's a culture shift. It's got to involve the entire population. Everybody has to be on board. It takes education. It takes some team building. It takes some problem solving together. My practice, and not every practice can do this, but once a year we have a staff development day, and we close and we all sit down together and we say, okay, how can we tackle this problem? And you know what? We care managers can't do it all. So who thinks that they can be in charge of doing this and keeping track of this? And really involving everybody on the team helps everybody feel vested in the care of the patients, and it really helps them be willing to participate. So it's a lot of education, repeating it. Don't stay in your silo, don't stay in your bubble. Be out there and engage and engage the clinicians and engage the MAs and engage the front desk staff and the billing staff, and really make it a culture shift. Sorry, I was 10 minutes over. It's Laura's fault. She made the slides. And the video, that was Amanda's fault. She made us watch the video. Guys, I have time. I know you guys have to get back to your clinics, but if you have questions, please ask. I'm happy to answer them. If you have specific ACO related questions, Laura and Joanna's emails are here. We will share slides. I don't know how they do that.
Yep, as long as you signed in, we know that you were here, and we will send you the slides by email.
Thank you.
That's simple enough.
So, and if you have any questions, I will stick around and answer them.
I do have a couple questions.
Sure, let's